So a woman, 70 years, falls on the outstretched hand. When we say outstretched hand, I don't know how to say it, but don't worry. I'll show you a diagram. Don't worry. And sustains an injury to her right wrist. So there's what an outstretched hand falls on it, an outstretched hand. So normally, what happens when you fall is that there can be what? A fracture, or a bone can break, or a broken bone. Let me put it that way. There can be a broken bone. And this broken bone is normally, with an outstretched hand, it normally falls on the radius, or your radius. Yes, so the radius is very, anytime you fall, that particular bone is very, very, very at risk of getting fractured. I don't know. Maybe it's not too strong as the ulnar. I don't know. But that one, it always fractures. It always fractures. So put that one at the back of your mind. So definitely, considering the mechanism of the injury, what is the most likely diagnosis? The mechanism, an outstretched what? Hand. Definitely, like I said, a fracture of the what? Of the radius. And the term we give it is called what? A Colles fracture. Colles fracture. Colles fracture. Colles fracture. But don't forget, so that's why I said I'll show you a diagram. There's a difference between a Colles fracture and Smith fracture. Smith, the name Smith, S-M-I-T-H, Smith, and Colles, C-O-L-L-E-S, Colles fracture. So opposite of Colles is the Smith. So whilst Colles, there will be an outward fracture. With the Smith, there will be an inward fracture. I'll get a diagram to illustrate what I mean by outward and then inward. Okay. But over here, we're talking about a Colles fracture because of the mechanism of what? The injury. That's what? Falling on the outstretched hand. All right. So what would be the nature of displacement of the bones injured? So your radius, what could be the nature of the displacement? That in what direction can it go? So one, it can be dorsal. It can be dorsal. I think I remember this. So now an outstretch, meaning that you have used the dorsal part of your hand on the floor, or you have injured that part. The dorsal part, the dorsal part, the dorsal part. Not the palm, the dorsal, the back of your hand. So that's the part that you have used to hit on the ground. So we can talk about the dorsal. So the bone can be dorsally displaced, or radially displaced, or supinated. Supinated. So again, dorsally, radially, or supinated. Supinated. All right. Now, those who have been following me with Croc, anytime there is a bone or musculoskeletal injuries, which tests or which investigation will you normally do? Of course, X-rays. So never forget what your X-rays. When it comes to musculoskeletal problems, always your X-ray should be paramount to you. So over here, you do an X-ray of the wrist. You can do the posterior anterior and the lateral view. So PA and lateral view. PA and lateral view. Why you have to do the PA and lateral view is because if you look at a thing in AP view or PA view, and you do the lateral one, so lateral one will tell you where the thing is displaced or how it's displaced and all of that. Okay. AP or PA can tell there's a fracture here, but you don't really know whether it is curved this way or moved that way or moved that way. But lateral view will tell you how it has displaced. Just have to do both so you can know how best to help the patient. All right. Then indicate 3 modalities of anesthesia for reduction and fixation of this injury. Good. So what kind of pain relief will you give to the person if you want to do a reduction and fixation? Reduction and fixation. Some people might not really use, so fine. So you can do what you call the, how do you call it? You know, you can apply POP, right? But before you can apply the POP, you have to what? Reduce it. You have to reduce the fracture. You have to reduce, because the fracture will have displaced, isn't it? So you have to put it back the way it was before you can do your POP or whatever modality you want to use to treat the patient. All right. So one, we can talk about what? The general anesthesia. General anesthesia. You can talk about the auxiliary block. The auxiliary block. Then you can talk about intravenous regional anesthesia. So again, general anesthesia, auxiliary block, intravenous regional anesthesia, also called the bias block. Bias block. So B-I-E-R. BIA, or I don't pronounce it. The BS block or the BS block. Or the intravenous regional anesthesia, as simple as that. General auxiliary. So all of these things should be your modalities in doing that. Yeah. Exactly. So I'm saying POP. So POP is a cast, actually. Wonderful. Okay. So good. So this is what I wanted to show you guys. So this is what a collet fracture. Okay. Now look at it. So this is your ulnar, your radius. So when you fall on your dorsal aspect of your hand, okay, this part can break. So you can see it's broken. You can see it's broken. So that is what? A fracture. That's what a fracture. And this is the collet fracture. But look at it over here. The collet and then the Smith fractures. Look at it. Look at how the collet fracture is. So you see the collet fracture is. So the dorsal aspect is broken. Okay. The dorsal aspect is broken. And look at over here. This one, the inward is so the palmar area is what is injured. The palmar area is what is injured. So take note of the following. Take note of it. So that's the difference between what? The collet fracture, that's outward, and then the Smith fracture, which is what? Inward. And then the Smith one is very, very, very dangerous. Why? Because it involves a lot of what? Neurovascular structures over there. Neurovascular. They pass there a lot. So it's very, very serious. But we hardly get Smith. Most of the time that we see normally is the collet fracture. Because of the fall, you want to protect yourself from the fall, isn't it? And that leads to the fracture. All right.